Today, my talk is going to focus on our ongoing work at the University of Michigan, which is really utilized a unique vascular surgery collaborative we have the opportunity to work with within Michigan, as well as our work in improving vascular care for the state. So I have no financial disclosures. So I'd like to start off my talk today by referencing a quote that one of my early research mentors had when we were discussing projects to potentially work on during our research time. And he stated that it's important to investigate topics that frustrate you in the current healthcare setting so that you can make an impact for yourselves as well as the patients you care for. And in reality, it was this interaction with my early research mentor that has really shaped my philosophy in academic vascular surgery and how I approach certain problems within vascular surgery care. And whether it's within my basic science laboratory, where, as Dr. Lee pointed out, I investigate the pathogenesis of abdominal aneurysms in animal models and translational studies, or when conducting clinical outcomes projects, it's kind of my overall goal to conduct impactful research that can really drove my approach to topics in vascular surgery care. And I feel like for good or for bad, the vascular surgery specialty, and especially overall cardiovascular care, is ripe with opportunities for us to conduct impactful research that can alter patient care. Indeed, the field of cardiovascular specialty has recently fallen under the microscope with investigational studies published by either the New York Times or ProPublica, which have highlighted the variability in both the appropriateness and quality of care that patients afflicted with peripheral arterial disease receive within the United States. And clearly, these are definitely opportunities for us as academic physicians to conduct research projects to make impact for both ourselves as well as the patients who are afflicted with a variety of vascular surgery conditions. And within this context, the state of Michigan, as well as the University of Michigan, has worked hard to analyze and improve care of vascular surgery patients within our state. Specifically within the state of Michigan, we have developed a unique collaboration with one of the leading insurance agencies within the state of Michigan, Blue Cross Blue Shield. And this Blue Cross Blue Shield of Michigan Vascular Intervention Collaborative is a multi-institutional collaborative across the state of Michigan and represents 35 hospitals, which are pictured here on this map. And within this collaborative, we collect information as well as on all vascular surgery procedures and their associated outcomes. And this Blue Cross Blue Shield Vascular Intervention Collaborative is a database that's maintained by a set of trained clinical coordinators and is blinded to hospital-specific results. As such, the goal of this collaborative is not necessarily a punitive measure for individual hospitals or individual surgeons, but rather the goal of the collaborative is to work to overall reward quality of care as well as adherence to best practice guidelines within the state of Michigan. In addition, this collaborative adopts a pay-for-performance setup in which quality metrics within the Vascular Intervention Collaborative are jointly agreed upon by both the participating healthcare systems as well as the Blue Cross Blue Shield Insurance Agency. Hospitals that are able to achieve these quality metrics can then go on to obtain a financial bonus with a 5% payment on over top their initial operating payments if they were able to achieve a certain set and number of the metrics that they agreed upon. In this manner, there's kind of joint buy-in from both the hospitals that are participating as well as the insurance agencies to overall improve both the financial conscientious care and quality of care within the state. And harnessing the power of this database, we have utilized to both study vascular surgery outcomes within the state, as well as both design and implement metrics to potentially improve outcomes across our catchment area. Today, I will highlight our ongoing work kind of within this Vascular Intervention Collaborative, specifically referencing 3 of our research projects within the collaborative that have worked to improve care. The topics I'm going to specifically discuss today is our ongoing work on surgical site infection after lower extremity bypass, our interest in the variation of elective management of small abdominal aneurysms within the state of Michigan, as well as the importance of long-term surveillance after endovascular aortic aneurysm repair and how do we design metrics to optimize long-term surveillance for endovascular patients. So the first project I'm going to talk about is our ongoing work related to surgical site infection after lower extremity bypass. So as we all know, surgical site infection after lower extremity bypass, unfortunately, is one of the most common complications we as vascular surgeons have to deal with within our patient population. Current literature suggests that the reported incidence of surgical site infection ranges between 4 to 22% after patients with peripheral arterial disease undergo lower extremity bypass. Work on lower extremity bypass and postoperative surgical site infection has demonstrated that surgical site infection has significant increase in morbidity and mortality after operations. It can lead to increased length of stays for patients, the need for reoperation, as well as increased mortality for patients who suffer a surgical site infection. In an effort to understand the associated risk factors for surgical site infections, there's been a variety of studies which have looked at both patient and procedure-related risk factors for surgical site infection. Within these patient-derived risk factors, prior studies have shown that female gender, BMI or obesity, diabetes, as well as dialysis dependence are all independent risk factors for surgical site infection after lower extremity bypass. However, more recently, within general surgery procedures, the American College of Surgeons Best Practice Initiative has also demonstrated that beyond patient-derived risk factors, hospital-specific risk factors or process of care measures within given hospitals can also be independent risk factors for surgical site infection. However, the risk for hospital factors and their relation to surgical site infection after vascular surgery procedures, specifically lower extremity bypass, has not been vigorously investigated. In an effort to decrease surgical site infection after lower extremity bypass, I think it's really important that we understand all the associated risk factors for surgical site infection, as although some of these risk factors might be not modifiable, some might be modifiable, and then we can design metrics around these risk factors to decrease the rate. So as such, the objective for this first study was we sought to characterize the incidence of surgical site infection after lower extremity bypass within our statewide and catchment area in the Vascular Intervention Collaborative. We then sought to understand that independent patient, procedural, as well as hospital-related risk factors that could drive surgical site infection. And lastly, we sought to identify the effect of surgical site infection on the 30-day postoperative morbidity and mortality for associated patients. So for our patient cohort, we collected information on all elective and urgent lower extremity bypasses within that statewide vascular intervention collaborative between January 2017 and June 2020. In total, that included 3,992 patients, and after exclusion of a minor amount of patients, we were left with 3,443 patients. We collected information on patient demographics, medications, procedural characteristics, as well as the hospital characteristics at which place they received the bypass. And as I've mentioned, our primary outcome for this study was the incidence of surgical site infection within 30 days of the index operation. And we constructed both unadjusted and adjusted analysis of surgical site infection risk factors. When we first looked at the patient characteristics, of the 3,443 patients who underwent lower extremity bypass during this period of time, 9.3% developed surgical site infection within 30 days of the index operation. At the patient level, we found that obesity was related with patients who developed surgical site infection, but there was no significant difference in patients who had an elevated age or were current smokers. We did denote that patients who developed surgical site infection had a higher comorbid cardiovascular disease burden, as shown here by a number of different cardiovascular risk factors. Moving on, we also found that patients who developed a surgical site infection were more commonly presented with an increased severity of their symptoms for peripheral arterial disease. And this is documented by their answers and worsening answers on the peripheral arterial disease questionnaire score, as well as their presentation with either rest pain, ulceration, or acute limb ischemia. In regards to the procedural characteristics, we found that preoperative antibiotics were appropriately administered in 97% of patients who underwent a lower extremity bypass, irregardless to whether they received a surgical site infection or did not develop a surgical site infection postoperatively. Now, this is one of the metrics within the Vascular Intervention Collaborative, and as such, it demonstrates a high compliance across the vascular group. We then analyzed the specific procedures that patients underwent and found that infragroinal procedures were more commonly associated with surgical site infections in comparison to other procedures. At the operative risk factors, we found that intraoperative transfusion level, prolonged procedural length of greater than 240 minutes, as well as peak intraoperative glucoses were all significantly associated with surgical site infection. And as I've demonstrated and talked about before, prior investigations have referenced that hospital structural and process of care characteristics could also influence surgical site infection postoperatively. Within our study, we had a broader range of hospitals that contributed data to this cohort, and there's wide variation in terms of the size and the number of hospital beds, the trainee ratio at given hospitals, as well as the overall operative volume and lower extremity bypasses at those participating hospitals. Now, ultimately, we conducted an adjusted analysis of all the patient, procedural, and hospital factors within this cohort to try to determine independent risk factors for surgical site infection. At the patient level, consistent with prior studies, we demonstrate that obesity, as well as hemodialysis dependence at time of operation, were independent risk factors for surgical site infection. But we also demonstrated different risk factors in terms of prior vascular surgery, hypertension, as well as patients' responses to the PAQ symptom severity score at time of their initial operation. In regards to the procedural risk factors, we found that iodine-only skin preparation, peak intraoperative glucose levels, as well as prolonged operative length were all significantly associated with surgical site infection postoperatively. And lastly, hospital characteristics, including a major teaching hospital or what was deemed a small hospital of less than 500 beds, were risk factors for surgical site infection. In regards to the 30-day morbidity and mortality, patients with surgical site infection were at increased risk of a need for postoperative transfusion, as well as the need for a major amputation. Unfortunately, patients who developed surgical site infection were also at elevated risk for the need for an open bypass surgery revision. We found no significant difference in the risk of overall mortality at 30 days in patients who did or did not develop a surgical site infection. Now, ultimately, from this study, using the Vascular Intervention Collaborative, we demonstrate that unfortunately, the incidence of surgical site infection after lower extremity bypass in the state of Michigan is about 9.3% for a broad kind of catchment area. And surgical site infection leads to an increased risk of amputation as well as open bypass revision. Within this study, we identified a variety of patient, procedural, and hospital-related risk factors that are associated with surgical site infection. Now, unfortunately, many of these risk factors are not modifiable. We cannot control if somebody presents to us with hemodialysis dependence already prior to their operation. We can't control if they presented and already had a prior vascular surgery at an outside hospital. However, some of these risk factors are modifiable. The operative length of time that we as the surgeons take to perform an operation, the peak intraoperative glucoses that the anesthesia team are monitoring during the case, as well as the use of iodine-only skin preparation prior to surgical incision. So as such, with these modifiable risk factors in mind, we've now went back to the Vascular Intervention Collaborative and designed new metrics that hospitals can now adhere to prior to the lower extremity bypass. Specifically, now within the Vascular Collaborative, it's a mandatory reporting that all patients who receive a lower extremity bypass, there has to be reporting on the overall operative length with one of the goal metrics less than 240 minutes, peak intraoperative glucose levels during the case with a goal less than 180, as well as the use of chlorhexidine antiseptic skin preparation instead of iodine-only skin preparation. Our hopes is that by implementing these new metrics into the Vascular Intervention Collaborative and these modifiable metrics, we can thereby decrease the rate of surgical site infection moving forward for our PAD patients and our lower extremity bypass patients. So kind of the next project I want to talk about is kind of a change of gears, but I want to detail our also ongoing work looking at the variation in elective management of small abdominal aneurysms within the state of Michigan. So as we all know, the management of abdominal aneurysms can be complex. Patients present with a variety of preoperative risk factors. There's associated operative risk of patients who undergo either endovascular or open surgical repair, as well as there's risk of rupture for aortic aneurysms based upon their aneurysm anatomy. And historically, to guide our care of patients with abdominal aneurysms and just determine whether to intervene or not intervene, it's often been guided by the maximal aortic diameter of the patients that they present. And as such, the Society of Vascular Surgery has recently reached consensus guidelines for the care of abdominal aneurysm patients here within the United States. And one process measure within these guidelines is that patients who have undergone elective repair of an abdominal aneurysm, when that aneurysm reaches either 5.5 centimeters in men or 5 centimeters in women. However, are these benchmarks actually being met? Are patients being repaired at that diameter, or are they being repaired before that diameter? Prior studies conducted both nationally and internationally have demonstrated that these benchmarks are not actually being met. The studies referenced here demonstrate that approximately 5 to 40% of abdominal aneurysms are actually being repaired below a guideline size recommended therapy, or less than 5.5 centimeters in men, less than 5 centimeters in women. In addition, studies have also demonstrated within the United States that there's regional variation across the country in terms of the elective management of small abdominal aneurysms following endovascular repair. The study here actually demonstrates that the highest percentage of elective aneurysms performed before small abdominal aneurysms, again, aneurysms below typical guideline recommendation, actually occurs in the southeast of the United States. One interesting finding from this study was actually this regional variation in the care of patients with small abdominal aneurysms was significantly associated with the market competition within that given region. Now, these studies, while informative, are often confounded by the inability to distinguish truly symptomatic versus asymptomatic and elective abdominal aneurysms, as well as the inability to understand the physician or the patient rationale in terms of why those aneurysms might have been intervened on at what diameter that was typically below a typical guideline. So as such, for this study, we sought to determine the variation for small abdominal aneurysm management within the state of Michigan specifically. In addition, we sought to better understand the real-world physician rationale in terms of why selected physicians or patients might seek to undergo repair of a small abdominal aneurysm below that typical guideline size recommended therapy. And lastly, we sought to identify if the impact of adherence to guideline size abdominal aneurysm repair has an impact on 30-day and 1-year morbidity and mortality. So for this study cohort, we specifically collected information on all elective abdominal aneurysms at the 35 participating hospitals between January 2016 and June 2020. We specifically excluded patients who had symptomatic status at time of presentation or a ruptured aneurysm, as we sought to only look at an elective aortic aneurysm repair population. Within this, across the state of Michigan, of the 3,786 elective abdominal aneurysms, 340 were repaired in an open fashion, and 3,446 were repaired in an endovascular fashion. For these patients, consistent with our other studies, we collected information on patient demographics, medications, as well as procedural details. And ultimately, for this cohort, we arranged patients into 2 separate blocks. First were those patients who underwent either an open or endovascular repair in what was deemed a guideline size aortic aneurysm. The second group of patients were patients who underwent either an open or endovascular repair in what was deemed a small abdominal aortic aneurysm. And for this study, we specifically defined small abdominal aneurysms as those aneurysms that were less than 5.5 centimeters in males, less than 5 centimeters in females, or who had a growth rate of less than 1 centimeter per year, which was deemed as a slow-growing abdominal aneurysm. And we sought to understand the variation in aneurysm size, the rationale for physician intervention on a small aortic aneurysm, as well as its impact on morbidity and mortality. So for our study cohort, of the 3,786 abdominal aneurysm repairs, 469 or 12.4% of the aneurysms that were being repaired in the state of Michigan during this period of time were deemed small abdominal aneurysms, so below a typical guideline size recommended therapy. We then went on to analyze the patient characteristics for both small and guideline size abdominal aneurysms. And shown here, there's a high prevalence of cardiovascular comorbidities in both groups, the groups that were small abdominal aneurysms, as well as the guideline sizes of abdominal aneurysms, with equal distribution of age, race, smoking status, as well as COPD, thereby suggesting that it's not necessarily the patient risk factors or comorbidities that push physicians to intervene or not intervene at a small size. Moving on, we also analyzed hospital characteristics. And across the state, there was a large diversity of the hospitals that treated abdominal aneurysms. As such, we found that large hospitals or hospitals greater than 500 beds were more likely to treat a small abdominal aneurysm, but there was no difference in either urban or rural hospitals or hospitals that were private practice versus an academic-based surgical center. And in order to gain further insight into the variation of small abdominal aneurysm practice within the state, we were able to analyze each individual participating system, both in terms of the percentage of small abdominal aneurysms they repaired during this study period, as well as the variation in overall aortic volume across each institution. And shown here is the percentage of small abdominal aneurysms that were repaired at each of the participating hospitals in the Vascular Intervention Collaborative. And you can see there's wide variation. Some hospitals, the Hospital of One only repaired 1.3% of their aneurysms were what was deemed as small abdominal aneurysms. Hospital 27 on the far hand side there repaired 40% of their aneurysm practice was a small abdominal aneurysm practice. Next, when you look at the variation in aortic volume over the 4 years, again, there's large variation in aortic volume over the participating hospitals. Some hospitals repaired as low as 9 aneurysms within a 4-year study period, whereas other hospitals repaired as many as 230 aneurysms within that 4-year study period. Ultimately, when we overlaid these 2 graphs onto each other and divided hospitals into tertiles, based upon their annual volume, we found that hospitals that had a low tertile of annual volume, or hospitals that operate on the lowest number of aortic aneurysms, had a more likely to repair small aortic aneurysms in comparison to other hospital health systems. In addition, within this study, and one of the key points of this study was we sought to better understand why physicians might elect to repair small abdominal aneurysms, even if these were below what guideline criteria would have meant. And as such, we did a retrospective review of all 469 small abdominal aneurysms that were repaired within this study window and sent surveys to the physicians who repaired those aneurysms. We then looked for responses from those physicians, and we received a total of 216 responses. Unfortunately, only a 46% response rate across the group. But these responses were specifically the physician rationale in terms of why they chose to repair that small aneurysm. And what we found is that the responses varied. In some physicians, they referenced that the patient had a family history of aortic aneurysm or aortic rupture that thereby pushed them to repair it at a small diameter. In other physicians, they referenced that the patient had a medical condition that also pushed them to repair that aneurysm. And they referenced poorly controlled hypertension, patients who had a COPD that was moderate in severity, or patients who had a general surgery or orthopedic surgery condition that needed an operation, but that operation would not be offered until their aneurysm was repaired. So another medical condition. Moving on, a moderate amount of physicians repaired aneurysms because of patient anxiety at 12%, aortic occlusive disease, or a thromboembolic event in which the aneurysm was deemed as the nidus for the thromboembolic event. In addition, physicians referenced that aneurysm anatomy was a big contributor to why they chose to repair aneurysms at a small size. A more detailed analysis of aneurysm anatomy and features that pushed physicians to repair small size aneurysms included a saccular connotation to the aneurysm and its configuration, or the combined presence of an iliac aneurysm that drove physicians to repair both abdominal aortic aneurysm and the iliac aneurysm at the same time. Yet, in addition, a moderate amount of physicians reported that they repaired small abdominal aneurysms because their specific practice patterns did not adhere to what was deemed as SVS guideline criteria. The physicians in these responses referenced that they chose to repair aneurysms typically on patients who are younger in age, female sex, a growth rate in which they referenced that was below that 1 centimeter per year threshold, or they deemed that if they continued to watch and wait for the aneurysm to grow, that a growth of the aneurysm might preclude them from doing an endovascular repair instead of an open repair. So as such, chose to do the endovascular repair at a lower size. In addition, beyond this, we then went on to analyze the 1-year morbidity and mortality for either small abdominal aneurysms or guideline size abdominal aneurysm repairs. And consistent with their prior studies, there was no difference in 30-day or 1-year morbidity and mortality for small or guideline size abdominal aneurysms. However, I do want to point out that even in the small abdominal aneurysm cohort, there was 8 patients who had amputation, 7 patients who suffered a myocardial infarction, and unfortunately 17 patients who died within 30 days of their index operation for a small abdominal aneurysm. And as such, I think this reference that aneurysm surgery is not without risk. And patients and physicians should not undergo aneurysm surgery unless that risk is necessarily warranted from a guideline size therapy. So ultimately, from this portion of the study, we demonstrated that within the Vascular Intervention Collaborative, 12% of elective abdominal aneurysms within the state of Michigan during the study period were performed for small aortic aneurysms as a high size. We also demonstrate that there's wide variation across hospitals. As I said, there's wide variation in terms of the percentage of hospitals that are repairing small aortic aneurysms, as well as wide variation in aortic volume. We find that there's a trend towards higher volume hospitals or higher aortic volume hospitals repairing less small abdominal aneurysms within their practice. In addition, we also understand there's variation in physician rationale. Physicians quoted that patient anxiety, aortic occlusive disease, as well as aneurysm anatomy all might push them to repair aneurysms at a small size. But we also highlighted that there are physicians within the Vascular Intervention Collaborative that feel that their personal practice patterns don't necessarily adhere to what are published Society of Vascular Surgery guidelines. And I think this variation in terms of both hospitals' willingness to repair small aortic aneurysms, as well as variation in physician rationale, highlights the difficulty in providing uniform and appropriate care across a large statewide and catchment area, especially for aortic aneurysmal disease. So with this data, we then went back to the Vascular Intervention Collaborative to try to improve the quality and consistency of care across the state of Michigan. So now, within the Vascular Intervention Collaborative, all physicians who repair a small abdominal aneurysm are given a survey at the end of that case in which they have to fill out a rationale for repairing that small abdominal aneurysm, referencing their personal criteria or different host of criteria. In addition, they're also given an active feedback form in which they're able to see their percentage of small abdominal aneurysm repairs in comparison to all surgeons within the Vascular Intervention Collaborative who participate in aortic surgery. And as I've previously mentioned, the purpose of this is not necessarily punitive for any individual surgeon, but rather the purpose is to promote equal and appropriate care across the statewide collaborative in order to provide uniform care for aneurysmal disease within the state of Michigan. So my last project I want to talk about today is our ongoing work with long-term surveillance after endovascular aortic aneurysm repair. And as we all know, over the past 2 decades, the treatment therapy and the treatment paradigm for aortic aneurysm has really become revolutionized. Specific pivotal trials, such as the OVER trial and the EVAR-1 trial, have shown that we can safely repair abdominal aneurysms in either an open surgical or an endovascular fashion, with endovascular therapy having significantly less perioperative morbidity and mortality. Further, as our surgical care is continually advanced, we can now offer a host of complex endovascular solutions for patients who are initially deemed too high risk for aortic aneurysm surgery. And as such, as endovascular surgery has continued to evolve, endovascular surgery has now become the primary mode of operation to repair aortic aneurysms. And now this data is clearly a little dated, but even at this time, endovascular surgery encompassed about at least 70% of the aortic aneurysm repairs that occur within the United States in comparison to an open aortic aneurysm repair. However, despite the early preoperative benefits and survival benefits of patients who undergo endovascular surgery, I think it's actually the long-term outcomes that are important and actually matter. As all large randomized trials investigating endovascular repair demonstrate that beyond the 3 years, that initial perioperative survival benefit of endovascular surgery has actually worn off. And indeed, patients who undergo an endovascular aortic aneurysm repair are higher risk of aortic-related mortality long-term or the need for secondary intervention. And as such, long-term surveillance for patients who undergo endovascular repair is important, as we can early identify potential leaks or stent graft complications, and thereby intervene on these aspects early in order to prevent aortic-related mortality associated with the aneurysm and the endovascular stent grafting. So in order to monitor the long-term durability of endovascular repair, again, the Society of Vascular Surgery has also published guidelines around that. They established that all patients who undergo an endovascular aortic aneurysm repair should receive a 1-month postoperative CTA or duplex, as well as an annual CTA or duplex moving forward for the remainder of that patient's life. The hopes is that by having these annual CTAs or duplexes, you're able to identify early problems with the stent grafting and intervene prior to them becoming bigger problems from an overall aortic-related mortality. Yet, are these benchmarks being met? Are centers actually adhering to follow their endovascular repairs long-term and thereby denote any complications that can occur well after they've seen them from the initial operation? And unfortunately, recent studies within both Medicare and non-Medicare populations have demonstrated that these metrics are not actually being met. Indeed, within the United States, 57% of the Medicare beneficiaries and 42% of non-Medicare beneficiaries are actually reported to not have appropriate long-term EVAR surveillance after their endovascular repair. And as such, within our study, our objective was kind of threefold for this portion. We first sought to analyze the contemporary trends in endovascular surveillance within the state of Michigan over our study period of time. We then sought to determine if the implementation of a performance metric designed around endovascular surveillance can improve the rate of long-term EVAR surveillance for patients within the state. And lastly, we sought to determine the impact of EVAR surveillance on 1-year morbidity and mortality for patients who undergo endovascular repair. So for our study population for this portion of the study, it included all patients who underwent elective endovascular repair between January 2017 and June 2021. And we specifically excluded patients who presented in emergent fashion with an aortic rupture, or patients who presented or had a repair with either a fenestrated or physician-modified graft. Our patient cohort included 4,107 patients, and we collected information on the patient demographics, medications, as well as their procedural details at the time of their implantation. And when we reviewed this cohort, unfortunately, we found that surveillance imaging was appropriately performed in 1,841 patients within the Vascular Intervention Collaborative, but was not performed in 2,266% of the patients within that intervention collaborative. When we started this study, we were interested to understand what was the baseline level of 1-year imaging surveillance within the Vascular Intervention Collaborative. And it really, to our dismay, the baseline rate of 1-year EVAR surveillance imaging within the state of Michigan, within these participating systems, was only 27.1%, so well below what we'd like to see within long-term follow-up. And following this initial finding of this low 1-year EVAR surveillance imaging, we then implemented a metric within the Vascular Intervention Collaborative designed to have hospitals achieve at least a 70% rate of follow-up for their EVAR surveillance long-term at 1 year. In addition, to better understand the factors that contribute to the absence of 1-year EVAR surveillance imaging, we investigated the patient, procedural, as well as hospital factors that might contribute to this absence. At the patient level, we found that patient risk factors that contributed to an absence of 1-year EVAR surveillance imaging or hyperlipidemia, COPD, as well as congestive heart failure. We found no significant difference in procedural characteristics that might contribute to an absence of 1-year EVAR surveillance imaging. We then conducted an adjusted analysis for the patient, procedural, and hospital risk factors that contributed to an absence of 1-year EVAR surveillance imaging. We found that diabetes, congestive heart failure, the annual emergent or urgent volume of the participating hospital, a non-home discharge, or the hospital bed census were all factors that increased the rate of incomplete 1-year EVAR surveillance imaging. In contrast, patient hyperlipidemia or the annual volume at a given hospital promoted 1-year EVAR surveillance imaging on our adjusted analysis. We also determined risk factors for reintervention as well as mortality at 1 year. Consistent with prior studies, the maximal aortic diameter was the strongest risk factor that predicted a potential need for reintervention moving forward. But we also found that the presence of surveillance imaging at 1 year was also a factor that contributed to reintervention, thereby suggesting that if surveillance imaging is performed, it can identify things that need a reintervention on. In addition, we conducted a just analysis for patient mortality at 1 year. And as expected, we determined several patient factors that were risk factors for mortality: age, smoking, preoperative creatinine, congestive heart failure. Those are all high-risk patient factors that are independently associated with mortality after EVAR. But for us, one really interesting finding was that we found that one of the protective factors for mortality at 1 year was whether or not the patient had EVAR surveillance imaging, suggesting that by long-term following these patients with EVAR surveillance imaging, you can either early detect risk factors for the patient or early detect failures of that stent graft that might lead to late aortic arrhythmia mortality or global mortality for that patient. So lastly, within the study, as I talked about before, in 2017, when we started this, we only had an EVAR surveillance rate of 27% within the state of Michigan. We were frustrated with that. It wasn't acceptable for us, in other words. So we designed that metric to try to improve this rate of EVAR surveillance imaging within the Vascular Intervention Collaborative. And then what we noted is after implementation of that performance metric, we had a steady increase in the rate of hospital EVAR surveillance imaging at 1 year, such that by 2021, we were able to achieve a 70.84% 1-year EVAR surveillance imaging across all participating hospitals. And when we look at the hospital-specific results from 2017 to 2021, you can see that across the board, many hospitals significantly increased the rate of 1-year EVAR surveillance imaging. And however, it should be noted that some hospitals, such as Hospital 1, had a marked increase in EVAR surveillance imaging, whereas other hospitals, such as Hospital 5, denoted here, did have an increase, but it was only moderate. So currently, we're working on delving into those hospitals that are deemed high performers for their EVAR surveillance imaging follow-up to better understand the systems that they implemented within their health system that allowed them to be so successful on their rate of EVAR surveillance imaging, and hoping to take those systems from a given high-performing hospital and uniformly apply them across the group to increase the rate of EVAR surveillance. So in conclusion, from this study, we demonstrate that EVAR surveillance imaging results in an increased number of reinterventions, but we also show that it is associated with a decrease in 1-year mortality independent of other patient risk factors. We also demonstrate that implementation of a large statewide performance metric can profoundly increase the rate of EVAR surveillance imaging. As I said, in 2017, we're at 27.1%, and in 2021, we were able to achieve a 70.8% follow-up for our EVAR surveillance patients. So in conclusion, kind of from my overall talk today, we're working really hard within the University of Michigan as well as the state of Michigan, utilizing the Vascular Intervention Collaborative to improve the care of vascular surgery patients across the state in a host of different projects. The projects I referenced today, we're talking about surgical site infection, identifying risk factors and designing metrics to decrease those modifiable risk factors, the abdominal aneurysm size criteria, and the wide variation in small abdominal aneurysm repair and how we can design metrics to decrease that variation, as well as EVAR surveillance. And I think the importance of long-term EVAR surveillance and how we can design and implement metrics to improve long-term surveillance within our state. So ultimately, we hope that by continuing to work with this statewide collaborative, we can both implement and test metrics that improve care of vascular surgery patients within our catchment area and overall improving the impact on the patients we see and provide care for on a daily basis. So I'd like to thank a number of my different collaborators, not only the Vascular Intervention Collaborative, which all the participants of that work really hard, but also a host of my collaborators at the University of Michigan as well as the University of Kentucky, who've helped make this research and my laboratory research pretty much move forward. Thank you for your time, and I'm happy to take any questions about our projects or the work.